Welcome to the Cardinal Minute with your host and chair of the University of Louisville Department of Medicine, Dr. Kim Williams.
Welcome everyone to the Cardinal Minute. This is Dr. Kristine Krueger, Chief of GI at the University of Louisville. Dr. McLean is behind me, and he's also co-chief with me. We are very happy today that this is the annual Richard N. Redinger Inaugural Memorial Lecture. Dr. Redinger was the longest tenured chairman of medicine in the United States, serving in that capacity here for close to 30 years, and he was also a bile acid researcher. So today for our grand rounds, we had Dr. Ashwani Singal, who is also a premier transplant hepatologist, researcher, chef, vegan cook, and he gave us a great lecture today on medical treatment for alcoholic liver disease. And we're going to let him have 60 seconds to give us the major bullet point take-home messages about alcoholic liver disease. Dr. Singal?
Yeah, and thank you once again for having me and giving this opportunity for this privilege. And Dr. Redinger's endowed medical grand round talk, and I thoroughly enjoyed. And the main points from the talk today would be, I think, just summarize the summary slides I had on the two summary slides. I think the first thing would be that patients who come to any medical encounter should be screened for alcohol use, and those who are at risk should then be screened for liver disease. So, and then once you find liver disease, and if they're not symptomatic, patients may be or should be evaluated for risk of fibrosis using serum markers, FibroScan, and other available depending on center to center facilities and expertise. Those who are either symptomatic or found to have an advanced disease like cirrhosis, could be compensated or decompensated, should be managed in a preferably in a center of expertise where hepatology expertise is available and especially transplant. Patients who have advanced disease, and if they're decompensated, especially with jaundice, there should be low suspicion for alcoholic hepatitis, because if you recognize it, and you could help some patients, especially in the short term. And this is what we did not talk during the talk. Even if you treat them with steroids during the acute phase, the benefit, survival benefit, is only limited to about 30 days or 4 weeks after initiating steroids. But that is sometimes enough to tide these patients, and if they remain abstinent, you can improve their long-term outcomes. Clearly, there are patients, and a large number of patients, I would say about 100,000 odd patients in America who get hospitalized for alcoholic hepatitis. They need new treatments, and there are drugs being, evaluated and assessed. But so far we don't have, and that's why it becomes relevant to integrate these patients into a model where you can treat liver disease and also their addiction and alcohol use disorder. I think that's important for these patients, recognizing that many of these patients don't end up getting treatment for their alcoholism. And I will stop there. Thank you.
Hey, thank you so much. Really appreciate all of that, all of your insights, and we're looking forward to seeing more methods for getting the right people to that particular therapy. And maybe we can do things in this country to cut down the incidence of alcoholic liver disease, really with your help. Appreciate it. And
that is the goal and dream, and I don't know, achievable dream.
All right. Well, this has been a Cardinal Minute. Thank you very much, Dr. Krueger and Dr. Singal.